Hey everyone, my name is Dr. Jeremy Seitz. I'm a pediatric intensive care doc in the Department of Pediatrics. Today I'll be sharing a lecture with you on pediatric respiratory disease, um, looking at upper and lower airway anatomy, physiology, and diseases of the upper and lower airway in pediatrics. I believe I have shared my screen, and we can jump into the presentation. All right. Wanted to quickly discuss the objectives for the lecture. As you'll see here, these are all taken verbatim from your syllabus. That was important for me to stick strictly to those so that you guys are getting the information that you need. So 5 objectives here. The particular things that I'll emphasize are highlighted in bold and in red here. So hopefully we cover all 5 of these topics. So let's break this up into 2 parts. Part 1, we'll discuss anatomy and physiology of the airway. Subdivided beyond that, we'll talk about the upper airway, normal anatomy, as well as common pediatric diseases affecting the upper airway. We'll then do the same for the lower airway and discuss common lower airway diseases in pediatrics. We'll talk about the pediatric airway versus the adult, and hopefully your take-home message from this is that there are some special considerations in pediatric airway anatomy when compared to the adult. We'll do an introduction to pediatric airway physiology, just a brief overview. And then finally, we'll talk about pediatric respiratory distress. And then after that, we'll jump into part 2 of the lecture. So let's start with the first section here on the upper respiratory tract. The anatomy of this is pretty simple and probably a review for most of you guys. The upper respiratory system, of course, starts with the entry point of airway into the body. That's at the level of the nose or the mouth, then enters either the nasal cavity or the oral cavity. From there, air will travel into the pharynx, and the pharynx is then subdivided into 3 sections: the nasopharynx, the oropharynx, and then the laryngopharynx, the portion of the airway just above the vocal cords. And so a simple way to remember the upper airway is just remembering that portion of the airway above the vocal cords. Here listed are some common infections that affect the upper respiratory system in children. The 2 that we'll focus on in part 2 of this lecture include epiglottitis and croup. What I do want to say about croup, when you're talking strict definitions of upper and lower airway, remember I said that upper airway is anything above the vocal cords. Croup will affect just below the vocal cords, and I think that's important to remember, just so that we understand the pathophysiology and the presentation of croup. But it is considered in textbooks and for testing purposes, and really just sort of in your mental filing cabinet, it's considered an upper respiratory tract disease. Let's dive now into the lower respiratory tract, including some basic anatomy. These are concepts you guys have probably heard, so hopefully this is a review, but let me cover it just briefly here for you guys. So if we're saying that the upper respiratory tract is anything above the vocal cords, and the lower respiratory tract will be the portion of the airway below the level of the vocal cords. Below the vocal cords, of course, you have the trachea and the tracheobronchial tree. The tracheobronchial tree will hit a fork in the road, a branching point at the level of the carina, at which time it branches into the right mainstem and left mainstem bronchi. The right mainstem bronchi will then further subdivide to make 3 lobes of the right lung. So that's right upper, right middle, and right lower. The left mainstem will branch to create 2 lobes in the left lung, so left upper and left lower. There are then a couple of subdivisions of bronchi from the mainstem bronchi. it subdivides into lobar bronchi. Lobar bronchi further subdivide into segmental bronchi. And then at that point, segmental bronchi branch into bronchioles. Bronchioles are an important anatomic component to remember because that's the pathogenesis of bronchiolitis in infants and young toddlers, which we'll talk about in part 2 of the lecture. Bronchioles consist of 3 subcomponents. So conducting bronchioles, terminal bronchioles, and finally respiratory bronchioles. And from the respiratory bronchioles, alveoli arise. So it's some very basic airway anatomy for you, just tracing the pathway of air below the vocal cords all the way to the alveoli. But here on the left side, you'll see a list of common respiratory tract diseases. Pretty much all of these are infectious. I take that back. RDS, transient tachypnea of the newborn, those are typically not infectious. Pneumonitis may be, but typically it's an inflammatory condition that occurs after a near-drowning event or an aspiration event. Cystic fibrosis is a chronic lung condition that affects children that often predisposes these children to infection. We won't really talk about that in this discussion. That's a disease that deserves its own 1-hour lecture. Bronchiectasis is a similar type of condition of the lung that affects children with cystic fibrosis, and children with bronchiectasis are often prone to infection as well, just like the CF population. Pneumonia, of course, is an infectious disease entity, maybe bacterial, viral, or fungal. Viral bronchiolitis, which we'll talk about in part 2 of this lecture, is certainly an infectious disease. And then asthma is not. Asthma is more of an inflammatory airway hyperresponsiveness type of condition. And we'll talk more about that in part 2. But of course, certain infections, such as upper respiratory tract infections, may trigger an asthma exacerbation. And again, we'll talk about that later. For the purposes of this talk, we'll really focus in on viral bronchiolitis and asthma. So this is a slide that's pretty exciting for the pediatric intensivist. Any budding intensivist or anesthesiologist in the room will perk up if they're in the room and they see this slide. Let's look over on the left-hand side at this picture. This was a picture captured with video laryngoscopy. So someone, maybe an ENT, a doc, maybe an anesthesiologist, maybe an intensivist, someone was accessing this airway with video laryngoscopy, and they were able to capture this picture. So that's pretty cool. What are these airway structures that I want you to at least be familiar with? Maybe tuck this picture away, and then when you're on your anesthesia rotation next year, pull this out and recall these structures. Structure A is the epiglottis, the omega-shaped structure, soft tissue that helps close off the esophagus from the airway. So it helps prevent aspiration of esophageal contents. We'll talk about the differences in the epiglottis in children compared to adults here in the next slide. Structure B, the arytenoids, an important cartilaginous structure, important for the person who may be intubating a child or adult who has a difficult view of the airway. In certain circumstances, the arytenoids may be the only discernible structure that the interventionalist, the proceduralist is seeing when they're intubating. So not really something to go into detail on this talk, but a structure that you should know about. C are the vocal cords. I want you to take particular note of these vocal cords because they're not the pearly white, pretty straight structures that are easily discernible from the rest of the soft tissue anatomy around it. That's very true and often the case in infants and small children, that the vocal cords may not be straight and white and pretty and perfect, that make them easily distinguishable from the airway anatomy around it. That can make intubating someone whose vocal cords look like this difficult. So I just want you to remember that, particularly in infants, the vocal cords may look more pink, like the tissue around it, than in adults, where they are typically white structures. D is the glottis, not really a structure per se, but more an anatomical space, the space occupying the area in front of the vocal cords. And then finally, E is the vallecula. You'll notice here this metallic structure above the epiglottis. That's the blade that was used to obtain this view, probably a Mac blade. Not really something for you guys to need to know right now, but will be useful for you if you do an anesthesia rotation next year. The vallecula is an important structure that individuals who are intubating need to know about in order to direct where their blade goes when they are intubating. So brief review of normal airway anatomy there at the level of the vocal cords. You can kind of think of the vocal cords as the transition zone between the upper airway and the lower airway. And then let's kind of transition over here to the right, the picture on the right side, just a pictorial to show you one of the key differences in childhood airway anatomy versus adult. Notice the conical shape of the infant's airway versus the very straight pathway in the adult airway. The cricoid, you'll notice that structure. That's typically the cricoid cartilage just below the level of the vocal cord is thought to be the narrowest portion of the pediatric airway. So an important consideration and pathophysiologically becomes important when we talk about certain upper airway diseases such as croup, which we'll get to soon. So let's talk a little bit more in the way of specifics on airway anatomy, pediatric versus adult. Number one, in infants, their head to the body ratio is much larger than older children and adults. So it makes their head more difficult to control, particularly when they're sedated and you're preparing them for intubation. So something to consider. Infants less than 6 months old are considered nasal breathers. You'll hear the term used that they're obligate nasal breathers. You'll see that in textbooks and probably on board exams. I think it's fine to think of them that way. You know, in truth, they're probably not obligate nasal breathers. I think pediatrics has moved away from that thought process. They are preferential nasal breathers, meaning that they do want and prefer to breathe through their nose, but they can breathe through their mouth when needed. And that the fact that they prefer nasal breathing is important when we talk about upper respiratory tract infections that obstruct their ability to breathe effectively through their nose that may send that child into respiratory distress. Point number 3, the newborn larynx is around the level of C3 compared to C5 in adults. And this is important because of the angle as well as the anterior nature of the airway. You'll see the angle here depicted on the right side, comparing the adult versus the child's upper airway. Point number 4, newborns and infants, their chin is relatively more retrognathic, meaning it's less prominent, it sits further back. That can make obtaining an effective view or performing bag valve mask ventilation. It can make those things more difficult. The mandible is relatively more hypoplastic, meaning you may not get the adequate jaw to mouth opening that you need when you're preparing to intubate. And then the tongue is relatively larger as well, meaning it is large, floppy, and can easily obstruct the airway. All of these things are accentuated and worsened when the child is heavily sedated as you prepare them for intubation. So these are important considerations in the child that you're sedating, about to paralyze, and preparing for intubation. We talked about how the larynx is more anterior in children compared to adult. I think in the last slide we covered the epiglottis a bit. It is larger and more floppy in children, particularly newborns and infants, and it can obstruct the upper airway. This point also becomes important when we talk about disease entities like epiglottitis, which we'll get to in part 2 of this talk. We did discuss the narrowest portion of the airway in children is thought to be the cricoid cartilage. just below the level of the vocal cords, versus in adults, it's believed to be at the level of the glottis. Remember that space just above the vocal cords that we talked about in the last slide. The trachea is shorter in children, particularly in infants. It's only 4 to 5 centimeters in length. This is important for the person intubating in terms of how far they place their endotracheal tube into the airway. Very easy to place it too far, to get caught up in the adrenaline of the moment, place the tube too deep, and then the endotracheal tube sits in the right main stem bronchus, and then you're only ventilating the right lung. You're no longer ventilating the left lung. A very common problem that we run into when we intubate children. So something to keep in mind, that the trachea is shorter in children, particularly in infants. And then finally, the tracheal rings are incomplete, and as such, they're more prone to collapse. And so disease entities like tracheobronchiomalacia are fairly common in young children. And that's where the airway collapses, especially in times of distress. And it obstructs airflow when it does so. So I think this covers the main points I wanted to hit on airway anatomy, adults versus pediatrics. So let's briefly talk about airway physiology. I don't want you to think you need to take some deep, physiologic or physics-based understanding of this away from what I'm about to tell you. I think important broad concepts are what I'm shooting for here. I think hopefully it'll make intuitive sense after you hear my explanation over the next couple of minutes. So all that said, let's talk about a couple of laws that you'll remember back in your days of physics and chemistry back in college. Ohm's law, you'll remember probably from physics in terms of electrical current and resistance to electrical current. Well, when we're talking about airflow in respiratory physiology, we use Ohm's law to help us understand the relationship between flow, which is Q in this equation, its relationship with pressure and resistance. And so you see Ohm's law in respiratory physiology is represented by flow equal to the change in pressure over resistance. And I'll talk about those components more in a minute, but resistance brings us to the consideration of Poiseuille's law, which is represented in the equation below that. Several components here that dictate resistance: viscosity, length of the tube, but most importantly is radius of the tube, such that when radius is decreased, that will be multiplied to the 4th degree. And so what does that mean? That means when the radius of the tube is cut in half, you actually have an increase in resistance by 16 times. So in children, this is very important because the airway is already smaller because the child is smaller, of course. And if you add a pathologic state causing airway edema, whether that's in the upper airway, like croup, or the lower airway, like bronchiolitis, that's going to further increase resistance. Increasing resistance, going back to Ohm's law, will change the flow of air into the airway. And the way to overcome that ultimately when resistance is high and airflow is obstructed is to increase the delta P. And delta P, in simple terms, in clinical terms, remember that delta P is increased when you notice your patient is in respiratory distress. So the person breathing comfortably, airflow is unobstructed, their delta P is normal. The patient in respiratory distress, that means that they're working harder to generate a greater negative pressure within the chest to drive more air into the chest because of obstruction of that airflow. And so I think that really kind of captures what I want you to know about Ohm's law and Poiseuille's law, just the relationship with airflow, delta P, and resistance, the fact that radius is the biggest most important indicator of airway resistance. So with this knowledge in mind, I want us to now transition to talking about laminar versus turbulent airflow. So that brings us here to this slide. We talked about Ohm's law and airflow, represented by Q. There's a couple of types of airflow that may be laminar or it may be turbulent. Laminar is airflow that is smooth and unobstructed. Think about this, think about turning on your water faucet in your kitchen sink and just watching that that water fall from the faucet to the sink in a very smooth pattern. You can interrupt that very easily by placing your finger or a utensil or a dish over that flow of water, and suddenly you've obstructed the flow of water and you have more of a chaotic pattern to the flow. This happens in the airway as well when there's things that are impeding airflow, whether that's edema, whether it's mucus, whether it's a foreign body like we might see in a toddler who's, aspirated a Lego or something to that effect. So as resistance increases, airflow moves from smooth and laminar to chaotic and turbulent. How does the body accommodate for that? Remember Poiseuille's law. The radius is smaller, so resistance is high. How do we accommodate that when we think about Ohm's law? Well, airflow, to increase the airflow, you're going to have to increase your delta P, and the body does that by generating larger negative pressure within the chest and increasing the work of breathing by a number of methods, which we'll see in the next slide. So I think that kind of captures what I want you to understand about turbulent and laminar airflow, very important concept in terms of respiratory disease. So in the next couple of slides, you're going to see some examples of respiratory distress in pediatrics. I've borrowed this picture here from Open Pediatrics, which is an educational web-based series in all things pediatrics, created by the Boston Children's Group, a phenomenal resource if anyone's interested in pediatrics. One of their lectures is on pediatric respiratory distress, and I used that in developing this talk. And this picture came directly from the talk. So I want you to look at this picture as we talk about some of the components, some of the signs of respiratory distress. Let's start first with stridor. Stridor is this sound that you hear on inspiration. It's a high-pitched sound indicative of upper airway obstruction, some impedance of flow within the portion of the airway above the vocal cords. Think, classically, most commonly for your all's purposes in your board exams, that's going to be from croup in the toddler who's exhibiting stridor. And we'll hear that. We'll hear an example of that in part 2 of this talk. So when you hear stridor, think upper respiratory disease, and croup should be on your differential. Next, I want you to notice wheezing. Wheezing, of course, is a sound that you'll hear audibly with as you're auscultating the chest. Sometimes it's so loud that you'll hear it audibly to the naked ear as well. But this is a sign of lower respiratory obstruction, whether that's inflammation of the airway, mucus, or perhaps even a foreign body that's made its way all the way to the right upper lobe. That can certainly happen. And audible wheezing, I want you to remember, is a sign of lower respiratory tract airflow obstruction. And it's heard on expiration versus stridor, which is heard on inspiration. The rest of these signs are more general signs of respiratory distress that can occur in upper or lower respiratory tract disease. So flaring of the nostrils, very common in children. Retractions, which can occur suprasternal, supraclavicular, intercostal or between the rib spaces, or subcostal below the rib margin. We'll see that in the videos and the slides to come. And then finally, seesaw respirations, really a sign of impending respiratory failure when the work of breathing is so severe that the chest and torso is literally heaving. Not listed here, but I think also an important one to remember is head bobbing, where the head is moving to and fro with each breath, also a sign of severe respiratory distress. So let's pause and watch a couple of videos here that exhibit increased work of breathing in children. Notice here below the rib margin, so subcostal retractions. Let's watch another short video demonstrating intercostal retractions. You can even see some belly breathing here. That's a sign of accessory muscle usage. Again, just a sign going back to Ohm's law that the body is accommodating to increase delta P because of obstruction of airflow somewhere in the airway. And finally, you see some intercostal retractions here, some subcostal retractions, certainly some belly breathing as well. All indicative of respiratory distress and all very common in the world of pediatrics. All right, guys, that really covers it for part 1 of this video. I'm going to pause this here and upload this to YouTube, and then I'll get on to part 2 of the lecture in the next video. Hope you've enjoyed it. Thanks for watching.